every single clinician faces, Troponin I versus Troponin T. These two are the heavyweights for detecting heart muscle injury, but they are not the same. Understanding the difference is absolutely key, so let's break it down.
Okay, so let's set the scene. You've got a patient in front of you with chest pain. Your clinical suspicion for myocardial injury is high, and the clock is absolutely ticking. You know you need to order a troponin, but which one? And does it even matter? Oh, you bet it does.
So, to really get to the bottom of this, we've got to start with the basics. What are we even looking for? Well, we're on the hunt for a clue. The clue, really. The one that's become the absolute gold standard in diagnosis.
Think of it like this. Myocardial injury, at its simplest, is the death of heart muscle cells. And when these cells die, they kind of burst open. They release their contents into the bloodstream. And one of those things they release is our number one suspect, cardiac troponin. And let me be perfectly clear, there is absolutely no debate about this. In the world of cardiology, troponins are the undisputed champs. They are the gold standard. When you see that level go up, you know there's been damage to the heart. But, and this is a big but, it's not quite that simple. Not all troponin tests are created equal.
All right, so let's meet the family. We've got our two main players, high-sensitivity cardiac troponin I and troponin T. Now, they have similar names, they do a similar job, so you might think they're basically identical twins, right? Well, spoiler alert, they are not.
I mean, on the surface, they look pretty similar. You've got troponin I over here, the one that's famous for being super specific to the heart, and then there's troponin T, which is incredibly sensitive, and of course a key marker for diagnosis. They both sound great, don't they? But as we all know, the devil is in the details. And those details are what we're about to unpack.
Okay, it is time for the main event. Let's put these two head-to-head and really see what they're made of. This is where the rubber meets the road, and you'll see why knowing the difference really matters.
So right out of the gate, they start off neck and neck. Both troponin I and T start to climb around the 3 to 4 hour mark. But then, their paths really start to diverge. See, troponin I hits its peak pretty quickly, within about 12 to 24 hours, and then it's back to baseline in about a week. Troponin T, on the other hand, it kind of takes its sweet time. It has a much broader peak and can hang around in the system for up to 2 whole weeks. Now, that longer window can be useful for sure, but it can also muddy the waters if you're trying to figure out if a new event just happened.
Okay, let's break this down even further. Look at this chart. The big one, the one I really want you to focus on, is cardiac specificity. Troponin I is the clear winner here. It's much less likely to be falsely elevated because of, say, skeletal muscle injury from something else. The timelines? Well, they just confirm what we saw in the last slide. And one last little tidbit. They're often run on different machines. Troponin T is pretty much a Roche game, while you'll see Troponin I on platforms from Abbott, Beckman, and Siemens. All right, now let's talk about a classic clinical curveball. This is where that whole specificity thing we just talked about goes from being an interesting fact to absolutely mission critical. I'm talking about our patients with chronic kidney disease. So here is the single biggest takeaway for this scenario. With chronic kidney disease, a patient's troponin T can just be high all the time, at their baseline. You can see how that would be a nightmare, right? Is it their kidneys or is it a new heart attack? But troponin I, it's much less bothered by poor kidney function. That means it gives you a cleaner, more reliable signal for a new acute event. For many clinicians, this makes it the go-to choice in this population.
And this is so important, I really can't stress it enough. A positive troponin means there's heart muscle injury, period. But it does not automatically mean heart attack. It's a huge piece of the puzzle, but it's not the whole puzzle. You've got to think about the differentials, things like myocarditis, sepsis, a big PE, severe heart failure, even renal failure itself can bump that troponin. The bottom line, you have to be a clinician, not just a lab reader. Always put it in context.
Okay, let's switch gears for a second. We've been saying HS this whole time. hs-cTnI, hs-cTnT. That HS stands for high sensitivity. And trust me, it's not just some fancy marketing term. It is a genuine game changer, and it's what gives you your diagnostic edge, especially in the ER.
So what does high sensitivity actually mean in practice? It means these tests are so incredibly precise they can pick up tiny changes in troponin levels, and they can do it fast. This is what allows for these amazing rapid rule-out protocols. You get a blood draw right when the patient arrives, that's your 0-hour baseline, then you do it again in just 1 or 3 hours. What you're looking for is a significant change, what we call the delta. If there's no real change, you can rule out a heart attack with a ton of confidence way faster than we ever could before. It's huge for everyone, the patient, the ER, the entire hospital system.
And this isn't some fringe idea. I'm talking about things like the 0/1 hour algorithm, which is recommended by major organizations like the European Society of Cardiology. It's all about leveraging this amazing technology to make faster, smarter, more confident decisions. It literally changes how we manage one of the most common and dangerous presentations in all of medicine.
So, after all of this, it really boils down to one simple but incredibly important question for you. Which troponin does your lab run? Seriously. Do you know if it's I or T? Do you know the specific cutoffs and the delta they use? Because all this theory is great, but what really truly matters is knowing the specific tool you have in your own hands. That knowledge is what's going to make all the difference for your next patient with chest pain. Thanks so much for joining me.